All right, I've got the recording on, everybody. I'd like to introduce you to your medical director, Dr. James Frame. And just for the purposes of kind of a roll call in case I forget and have to go back and look, starting we have Cody McIntyre, Jaron Shahan, Margaret Gonzalez, and Randy Gibson. If anybody else pops in after this, I just have to hope to catch them. And I did explain to them that at any point that they have to, or that you will check with them intermittently to make them participate. Guys, if Dr. Frame asks you to participate or you have something to ask him, click to unmute your microphone and then speak, and then remute it so the noise around you won't bother everybody else. But a smaller group, there's no reason why you can't, unmute your microphone when you have something to say or an answer to a question. That having been said, Dr. Frame, it's all yours.
All right, give me 1 second to set the view up here and we'll be good to go. All right, now is the slide clear to everybody? Jane, you can still see it?
I can see it just fine.
All right. Does it look like it's in full screen, or does it look like you can see the side slides too?
You can still see the side slides.
All right, that's what I'm trying to get rid of.
There you go. That's full screen.
All right. All right, today, this is going to be a 3-part lecture. So today we're going to cover one segment, and then we're going to get into another segment next month. And then the month after, we're going to complete it. Today, sedation and pain management, this is becoming a big topic on the National Registry exam. The pain management has been around for a gazillion years, but over the past 5 years, it's gained National Registry attention. We have different pain medications, sedatives, hypnotics, and neuromuscular blockers that we want to talk about over the next 3 lectures. Today, we're going to talk about sedation and the pain management piece. Now, your different EMS systems are going to come up with different formulations and different medications. For instance, most systems use morphine. Many systems have gone to morphine and fentanyl, and some more advanced systems have gone to morphine, fentanyl, and ketamine as a matter of pain control, as well as sedation, rapid sequence induction, or rapid sequence intubation, whatever you want to call it. And subsequently, the use of ketamine has become a big player. So we're going to touch on all of these things here in a second. Let me scroll up to the start of the slide presentation here. Okay, so analgesia is just that. How do we relieve pain? Different ways we can do it. You can bandage, you can splint, you can give some reassurance, you can give medications. All of these are pretty standard ways of relieving pain in patients. As we go through each slide, and I recognize something that I've seen on a national registry before, either through sample questions that I write for the registry, or that I have to review for the registry, or questions that I've seen on EMS testing, which could very well end up on a national registry, I'll certainly alert you to them. The top 2, I'm sorry, on this slide, only morphine and fentanyl are going to appear on the national registry. So I'm not going to get into Dilaudid and Demerol, except to say that you should know that Dilaudid and Demerol are out there as potential narcotics. I don't know any EMS system that uses Demerol anymore, although we did in the 70s, because that morphine was the only thing available. And hydromorphone Dilaudid, I'm not sure any EMS system uses Dilaudid. So morphine and fentanyl. Morphine is a naturally occurring substance from poppy plants, and fentanyl is a laboratory manufactured narcotic that comes about after purifying the poppy seed and other narcotics derivatives, if you will, such as heroin. Heroin being the most potent pain reliever on the face of the planet, fentanyl is a derivative of that. Subsequently, we use fentanyl a lot in trauma. Here is a very important point for the National Registry. Fentanyl is the narcotic and pain reliever of choice in trauma. The reason that it's the medication of choice in trauma, it does not affect blood pressure, but it does affect the patient's mental status and pain perception. For instance, we use fentanyl in the operating room. I can't think of a more painful place to be would be under anesthesia without having pain management along with it. You'd feel everything, even though you couldn't move because you're paralyzed. You'd feel the scalpel, you'd feel us pulling the muscles apart, you'd feel us cutting into the abdomen and excising different organs. Subsequently, when a patient is paralyzed for surgery, they're sedated with a hypnotic and they're given pain reliever at the same time. Fentanyl is the medication that we use in the operating room for pain control. It's about 88 to 100 times stronger than morphine. Morphine is the medication that we compare everything to. So fentanyl has obviously hit the popular press because of the number of overdoses, especially in the Ohio area where it seems to be manufactured most prevalent, but throughout the country. And it's because of fentanyl that Narcan, the nasal spray Narcan, went over the counter. It used to be a prescribed medication only available to EMS systems and emergency departments, but now it's been made over the counter because number one, it's got a huge safety profile. You can't virtually overdose on it. Second is that it only reverses one thing. It doesn't mask anything else. If it reverses it, if it brings somebody back to daylight, it was narcotic overdose. If it doesn't, then there's not a narcotic, at least being the major factor that's present. So same thing for morphine. Morphine, the quintessential medication, it's been around for before World War II and always used as a pain reliever. And you can go back to the days of early dentistry and medicine back in the mid 1800s, just after the Civil War, when they started developing medications like ether and such. Morphine was a big part of all that as well. We touch on analgesics such as Stadol and Nubane, but quite frankly, it's not in the National Registry, and I don't know any systems that carry it. If you belong to a system that carries it, let me know. I need to know that, but I think Stadol and Nubane have been pretty much disappeared from drug boxes throughout the EMS agencies throughout the country. Toradol is just starting to make an appearance in drug boxes. It's the IV form of Motrin. It's a non-steroidal anti-inflammatory. Subsequently, we use Toradol for inflammatory conditions. That does not include preoperative or suspected preoperative conditions. It means things like kidney stones, gout, things that cause inflammation in the body and the joints and such like that, or even for patients with chronic back pain that have herniated discs. Toradol has a very finite number of conditions that we can treat, but the conditions that they do treat, they're very effective. Now, like I said, morphine is the prototype medication that all analgesics are actually compared to on a milligram to milligram or milligram to microgram basis. In other words, this drug equals 10 milligrams of morphine. So if I give somebody 10 milligrams of morphine, yeah, I know what that feels like. Now, what do I need to give of the other drugs to make it feel like I just received 10 milligrams of morphine? Most of it's subjective. Some of it we can quantify in the lab, but for the most part, it's subjective through hundreds of thousands of patients where we've been able to kind of make a comparison. So for instance, 10 milligrams of morphine may equal only 0.1 milligram of fentanyl. In other words, 100 micrograms of fentanyl, and that's equal to 10 milligrams. 1 milligram of Dilaudid equals 8 to 10 milligrams of morphine. Dilaudid is pretty potent. So you can imagine if I give somebody 2 milligrams of Dilaudid, they would say, oh, okay, you're given a standard dose. But if I were to give 20 milligrams of morphine, even though it's the same pain relief, people would get all up in arms about 20 milligrams of morphine. My God, you're going to kill them. And yet I can give 2 milligrams of Dilaudid all day. It just, if it fits within socially accepted dosages and ranges, we feel better about it. I wouldn't profess anybody giving 20 of morphine, but yet I give 2 of Dilaudid all the time in the emergency department. It's just, you just got to get used to some nuances. So each one has different properties. Now, the only thing that you're going to hear about is going to be the mu receptors. You may get on occasion a delta or a kappa, mostly a kappa because it's spinal cord, but mu receptors, MU, are the quintessential pain receptors. When those receptors are stimulated, they're stimulated where pain is being transmitted up into the brain. To block that, we give opioids. And the opioids get to the receptor sites and actually block any pain sensation that the patient has. It does not block the cause of the pain. If I have an open femur fracture and I give 2 milligrams of Dilaudid, the patient's going to be pain-free and they're going to want to go home up until the time they try to stand up. The bottom line is that, remember, you're only masking the patient's perception of pain. You are not curing the painful condition. The mu receptors are receptors that we've identified in both the brain and spinal cord, and in some cases even the GI tract, where when the narcotic binds to it, it then blocks those receptors to pain, and the patient has the perception of feeling much better. Anxiety level comes down, heart rate comes down. Some cases, the blood pressure comes down because the stress has driven it upwards. Now, you may hear every once in a while about a kappa, but you won't see it on the exam. I just want you to know mu receptors for the exam. Okay, now when you go back over this talk in your spare time, just glance at this chart. It's the opiate conversion chart that we're just talking about. For instance, the morphine 10 milligrams is equal to Dilaudid 1 milligram, or 20 milligrams is equal to 2. Demerol 75 milligrams. Here's your fentanyl at 0.1. 1 milligram equals 100 milligrams of morphine. So 0.1 milligram or 100 micrograms would equal 10 milligrams of morphine. You got to do a little math there. Bottom line is that if you give fentanyl, it's either 50 mics, 100 mics, 150 mics, or 200 mics. Okay, we want to keep it to micrograms with fentanyl. 100 mics is usually what we use in the operating room, unless it's a deep surgery such as pancreatic or vascular repair way down deep in the abdomen or the chest. Definitely use it for brain surgeries. And it's not that the brain has any pain receptors, it's the coverings outside the brain that has all the pain receptors, but getting to the brain causes a lot of pain as well. So fentanyl is used a lot here. And keep in mind, we use fentanyl in the operating room because it does not drop the blood pressure. It has the least amount of histamine released than any other of the other narcotic medications. Subsequently, it's very favorable in trauma situations. If I want to put a badly injured 60 systolic blood pressure, 130 pulse rate patient who's unconscious, I may give 100 mics of fentanyl and then give some ketamine because that's safe in trauma too without dropping the blood pressure. Or I may roll right into fentanyl to ketamine and then a paralytic. Or I may just do fentanyl and ketamine. Or I just may do ketamine all by myself. It really depends because ketamine and fentanyl do not drop the blood pressure, whereas the other medications do. Dilaudid will bottom out your blood pressure, and so does morphine. But fentanyl, when used in the proper dosages, does not bottom out the pressure. Ergo, the strong recommendation throughout the country in emergency medicine, fentanyl is the drug of choice for trauma. So let's talk a little bit about morphine sulfate, and then we're going to skip right to fentanyl because you're not going to have to know the rest of it. It's a narcotic. There's a news flash. Yeah, morphine's been around since eons before. It is a narcotic. It's a CNS depressant, and it's a potent analgesic. So you're going to get great pain relief with morphine, but it's also going to make you a little tired, a little altered in your mental status. Knowing that it's a analgesic and it also causes sedation is a big advantage. Now, it increases peripheral venous capacity and decreases venous return, which is why we love using this stuff in congestive heart failure. You dilate the pulmonary vasculature with the administration of morphine. That then draws water back out of the lung. You give Lasix at the same time, and when that water is drawn out of the lung back into the bloodstream, the Lasix meets the water at the kidney and makes you urinate it out the body. So morphine and Lasix work in concert with each other to help clear up a congestive heart failure patient. If we want to decrease preload, in other words, decrease venous return even more, then I may put the patient on nitroglycerin if they're really bad CHF and their blood pressure can handle it. The beauty of morphine, great for this situation. Fentanyl does not give us this advantage that morphine does. Fentanyl will not dilate the pulmonary vasculature. So there's many of us within emergency medicine that prefer morphine in cardiovascular conditions, but prefer fentanyl in the trauma conditions. For instance, if I have a dissecting aortic aneurysm and the patient has a 200 over 100 blood pressure, I start them on a nitroprusside drip. I give them a big dose of laetolol, and I may slap some morphine on the patient to help them with the pain. And the morphine is going to help me drive that pressure down. Why? Because morphine is a big venodilator. Subsequently, you can bring a patient's blood pressure down. At the same time, the morphine will give some anxiety relief because it is a sedative as well. It's not quite the sedative of Ativan, but then Ativan is not the analgesic. With morphine, at least you get both qualities. So the only thing you really have to know for the National Registry is that it's an analgesic and also a sedative, that it decreases CNS levels of consciousness, and it decreases preload. In other words, decreases venous return. By getting the patient calmed down, getting the pain relieved, the heart beats a little bit slower now, and you're starting to get some relaxation. And as a result of that, the patient's myocardial oxygen demand, the so-called MbO2, drops down as well. And a patient is having a heart attack, that's a big advantage because you don't want the heart working real hard, giving it very little blood. If it's going to get just a little bit of blood, we want to make sure the heart's just working a little bit. So with morphine, our effects are almost immediate. You give 2 to 4 milligrams IV push in a patient who's having cardiovascular issues, heart attack, and you're going to get pain relief within a few seconds, 30 seconds, I think. Just enough time for it to squeeze through the IV tubing into the patient's veins, and it goes through into the heart if your IV is in the antecubital space or upper extremity, and it's going to go right to the heart, and it's going to go right through the heart, and it's going to bump right up to the brain and hit those mu receptors almost immediately. And that's the advantage of morphine. It's very quick on. Peaks in about 20 minutes, but you're feeling the effects almost immediately. Duration, it says 2 to 7 hours. I don't know anybody who gets 2 to 7 hours worth of relief from morphine. They're usually back on the nurse call button about 15 or 20 minutes later saying they need more morphine. Fine, they need it, give it to them. Now, it is associated with MI. That's the big one, cardiovascular. Burns, orthopedic injuries, kidney stones. Those are the big uses. Other forms of trauma, I'm not on board with this statement, neither is National Registry. We're going to hopefully get Pearson to take that off because we don't really want people using morphine in trauma. We don't want them to bottom out their pressure. Now, as a red patched paramedic, as a full-blown, no kidding, I'm certified paramedic, and you get out there and you got yourself a hot trauma going on, but this patient is not hypotensive, but they're hypertensive, then use your judgment. If you feel like you want to get some blood pressure control going on here as well, go ahead and shoot them with 2 to 4 milligrams of morphine IV push. Sometimes I order 10 milligrams of morphine IV push for like a severe burn where they've got their blood pressure over 200 or 100. I mean, I'll give them a big dose to drive it down. Why do I give them a big dose? Because if they start running into problems, what do? I either give them a little fluid bolus, or I put a little oxygen on them, and I'm standing at the bedside. I'm able to know any side effect or adverse effect that occurs. If you want to sneak up on it, do 2 milligrams and then 2 milligrams till they finally get pain relief. Fine. Either way you want to play it, it's fine. Just know that you'll get some blood pressure control benefit with morphine. Kidney stones are one of the 5 most painful conditions a human being can suffer, right behind MI and childbirth. One of those situations I prefer not to experience, but kidney stones definitely. MI patients have a lot of pain to the point where they're diaphoretic, look pale, and a lot of times it's due to low blood pressure, but a lot of times it's also due to the pain. If you've ever seen anybody with a femur fracture, they ain't looking healthy. And it's not because they're having an MI, it's because it hurts so bad that the patient actually starts vasoconstricting at the periphery because of the adrenaline release. Morphine does a great job there. Boom. Get the blood pressure down, get the patient relaxed, opens up the capillaries again, the patient starts feeling a whole lot better. Same thing with burns. Don't ever withhold pain medication from a person with burns. Burns are one of the most 5 painful conditions a human being can suffer. All right, what's the contraindications? Well, let's see, if we're going to drop the patient's pressure of morphine because it's too high, then I wouldn't use it if the blood pressure is too low. So some of these are duh statements. In other words, no kidding. I wouldn't use it in head injury because of the altered mental status and the drop in blood pressure that you'd experience in head injury. Hypersensitivity, in other words, I'm allergic to morphine. Okay, we won't use that. And of course, hypovolemia, if the patient is really dehydrated, you want to get them tanked up first before you give them morphine, or else what happens? I bet everybody out there is going to raise their hand right now to say, well, if you're hypovolemic and you vasodilate, guess what you get? More hypovolemia, not because they're losing fluid, but because you've opened up the venous system, and that amount of fluid that used to be in the venous system is not enough to fill up the new state of the venous system, which is venodilated, and you're going to drop the pressure even further. So good points to remember. The last one, we'll talk about that for a second here because this is a 3-part program. I'm not going to be rushing through this stuff. I want you to know this stuff cold. Undiagnosed abdominal pain. That was back in the day. That was back when I trained in the 80s as a doctor, in the 70s when I was a firefighter and paramedic. We didn't give pain medicine back then for abdominal pains because the doctor or the general surgeon would come down and they'd feel the patient's abdomen and try to figure out what's going on. So they'd feel the right lower quadrant. Are you having appendicitis? Right upper quadrant. Are you having a gallbladder attack? Left lower quadrant, especially in the older patients. Are you having diverticulitis? And we wouldn't use the pain medication back then because we wouldn't want to mask symptoms. Well, come the 90s, and Bill Gates and his brilliant discovery of how to make computers, computer technology, informational technology, next thing you know, we're in our 6th or 7th generation of CT scans. We can see everything in the abdomen. To now where the standard of care is, you don't take anybody to the operating room unless you got a CT scan. So we no longer rely on our physical exam anymore, but we rely solely on CT scans. Therefore, if I'm not going to be sending the patient to surgery based on my physical exam, I don't care if you mask their pain. Give them the morphine or give them the fentanyl, get their pain under control, bring their blood pressure down, bring their stress level down, bring everybody's anxiety level down, especially if family's present. Bring them into the ER. They're pain free. What's going on? They had a lot of abdominal pain, Dr. Frame. I had to give them some fentanyl, calm them down. No problem. Check off the labs that I need, CT scan, they haven't, poof, they're gone. They come back, they've got this, that, or the other thing. If they got something surgical, I call the surgeon. I'll tell the surgeon, hey, I think I got an acute appendicitis here. Is that what the CT scan showed? Yes. Okay. Now let's say the same phone call, I just examined the patient. I think it's appendicitis. I call up general surgeon and say, Dr. Surgeon, I think I got a hot appendix down here. Oh, really? What did the CT scan show? I didn't get one. All right, call me when you got the CT scan. Click. You know, no goodbye, no nothing. It's the click that says fool or idiot, and yet they don't say it to you. The bottom line here is that we rely on the CT scans now. So therefore, the undiagnosed abdominal pain as a contraindication narcotics is no longer a truism. Give them the pain medications. Okay, elderly asthmatic and those already susceptible to CNS depression, probably obvious. I'm not sure what the asthmatic has to do with it. Probably related to the histamine release that morphine can give certain persons, especially persons such as asthmatics who are a little bit hypersensitive to histamine. Histamine is a very powerful vasoconstrictor. It's a very powerful bronchoconstrictor. Subsequently, if I give it to one of you guys who does not have asthma or lung disease, you may do fine with the morphine. Yet if you give it to an asthmatic, they may be hypersensitive to it, which is why we like to start these patients at 2 to 4 milligrams IV push. If we hear that they've got asthma, and morphine's the only narcotic that we carry. This is why fentanyl is so popular in the asthmatic group as well as trauma group. It doesn't release histamine, or it's very, very minimal, to the point where even an asthmatic can tolerate it. Okay, side effects, everything. Everything causes everything. You can get nausea, you can get vomiting, abdominal cramps, constricts your pupils. That's not a side effect. That's a normal physiological response. When you stimulate a mu receptor by blocking it with an opioid, you're going to constrict the pupils. And it's one of 3 conditions that you have to know about when it comes to constricted pupils. And I may even ask you this on the medical director examination when you get that far. I may say, give me 3 conditions that cause constricted pupils. Let's see, narcotics, good. A stroke in the posterior circulation, especially the PONS, the so-called pontine stroke, exactly right. And if I shine a 1,000,000-watt bulb in their face, their pupils are going to constrict. That's a good one too. So you're going to get constricted pupils. That's usually a giveaway sign for narcs. If it's an 18-year-old, now if it's a 75-year-old and they're not on narcotics, I'd be thinking stroke. But certainly demographics, age demographics plays a big role in how to interpret constricted pupils. And of course, respiratory depression. Now morphine is notorious for respiratory depression. So giving it in 2 to 4 milligram doses is appropriate. Giving them in 8 to 10 milligram doses, yeah, well, you're really going to have to watch respiratory status. But you're red patch paramedics. You know what to look for. If the patient starts running respiratory problems, stimulate them, long rebreather, maybe an OPA if they start getting too somnolent, fine and dandy. It's okay to use a drug. Sometimes it's okay to have a side effect. Not every person responds the same way. Just be aware that this is one of the side effects and be prepared to treat it if you have to. But whatever you do, don't panic. And don't ever withhold pain medications because, oh my God, I'm afraid I'm going to cause respiratory depression. Well, then don't drive a car because you're afraid you'll get in an accident. Okay, when do they become problematic? When they've taken other medications. If you give a big dose of morphine and they just had 50 of Benadryl, that's going to make them tired. Phenergan, which is what we use for pregnant women who are vomiting a lot, that have also abdominal pain. If you give morphine in the presence of Phenergan, you can cause some decreased CNS depression. If a person is on Phenergan, or if you plan to administer Phenergan with your narcotic, cut the narcotic dose in half. For instance, if I'm going to give 1 milligram of Dilaudid, or if I'm going to give 10 milligrams of morphine to somebody because they got a lot of pain, I'm going to add 25 milligrams of Phenergan. Because I'm adding an antiemetic to their pain management, I cut the morphine in half to 5. Because antiemetics, and we're not talking about Zofran, we're talking Reglan and Phenergan and Compazine. Those class of antiemetics cut the requirement for the narcotic in half because they of themselves have relaxation properties to them. If you give a normal dose of narcotic with a normal dose of an antiemetic such as Phenergan, you could cause oversomnolence and CNS depression. So watch that. If your patient has already taken Benadryl or Phenergan or Compazine or Reglan, adjust your narcotic dose accordingly. And of course, any one of the sedatives, yeah, I just took, my standard 2 milligrams of Xanax for my anxiety, but I'm having a hell of a lot of pain. Okay, cut your morphine in half. And then of course the big one, watch the alcoholics. Anybody who's been drinking quite a bit, alcohol in and of itself is a CNS depressant. And as we all know from watching other people, not us, cheers, that alcohol can also potentiate narcotics. It doesn't just go additive like Phenergan or some of the other meds. It potentiates. So in the case of Phenergan, morphine plus Phenergan equals 2. 1 plus 1 equals 2. Yet morphine plus alcohol equals 3. 1 plus 1 equals 3. Together, they're more than the sum of their parts. And that's potentiation. That's a higher standard. So watch the alcoholic. Wouldn't be in a hurry to give narcs to an alcoholic if they're having that much pain, unless they got something really obvious going on. And then even then, I may only give them 2 to 4 milligrams of morphine if I really have a strong suspicion that this person is not only intoxicated, but they're 3 sheets to the wind. Okay, so we go 2 to 10 milligrams IV push is the standard dosing. Try to keep it to between 2 and 4 if you're concerned about blood pressure issues. It can be administered IM as well. And we give it with Zofran, Phenergan, Reglan, Compazine. Just watch it once again. Now, Zofran's beautiful from the standpoint, it doesn't potentiate anything. It's not even additive to anything. Morphine plus Zofran equals 1. Morphine is 1, Zofran equals 0, therefore 1 plus 0 is 1. Zofran doesn't add anything to CNS depression or nothing. It's a pure antiemetic, which is why Zofran is so hugely popular with folks. Okay, any questions on morphine?
I have a question, sir.
Go ahead,
This is
Randy.
Randy. Hey. I know a lot of protocols where I'm at are giving Benadryl with narcotic pain management for an antiemetic. How do you feel about that?
I like it.
You like it?
I do. Two reasons. Number one, most abdominal pains are due to some degree of histamine release. So the Benadryl can get in there and work almost immediately. And if you've used it in allergic reactions, you can see it works pretty damn fast if there's a histamine mediated pain. Second is if you give morphine with the Benadryl, and the morphine does tend to release histamine, the Benadryl is right there to block it. And the most powerful antihistamine in the world is Benadryl, diphenhydramine. So I like it.
Okay, thank you.
No problem. Anybody else with a question? Jerron, Cody, and that new young student we have, Jane Dinsmore. Jerron, go ahead.
I had a question about fentanyl, but I mean, it's probably going to be answered when we go through it. I know morphine can't do it, head injuries. Is fentanyl the same way?
You know, we use fentanyl in closed head injuries to help patients that are having pain when they have a combination of things going on. So a closed head injury plus an open femur fracture, a traumatic subarachnoid hemorrhage, or even a non-traumatic subarachnoid, but for the most part, it's a traumatic subarachnoid hemorrhage associated with a fractured neck. That's a hell of a lot of pain. So we'll go ahead and give fentanyl for that as well. The advent of the days where we're worried about a person going to sleep because they got a bad head injury, again, gave way to CT scan. If we don't see anything on the CT scan, epidural or subdural, patient's clean and we're perfectly able to get through the narcotic. What you're going to find out about fentanyl here in a few minutes is that it's fast on, fast off. I give it, its effects are almost felt immediately, and 15 minutes later, it's gone, which is why in the operating room, we have to give it every 15 minutes. So if you give 100 mics of fentanyl to a closed head injury out there because they're having a hell of a lot of pain because they got whacked in the head, I'm all over it. You're good with that.
Okay, thank you.
Yeah, I had a similar question, but just answered it. So.
Okay, very good. And Miss Dinsmore, teacher's pet, do you have anything?
No, sir. I'm just still here, just listening patiently and learning myself.
Yeah, okay. All right, fentanyl, narcotic analgesic. 50 to 100 times more potent than morphine. Excuse me, let me sneeze here for a second. Oh, sorry about that, folks. Okay, so it's not related to morphine. Why? Because morphine's naturally occurring and fentanyl is made in the laboratory. Purification process and such. You need a very sophisticated lab to make fentanyl. The bad guys have already figured that out and they're putting purified fentanyl out there, which is why we're having so many overdose deaths that are out there. And it's not really an overdose. They've been taking their normal dose of fentanyl, but because the fentanyl is so highly purified, a 10% fentanyl, which is typically what's out there, when the bad guys purify it to 50 or 60%, you know, you're getting 6 times the dose. Subsequently, respiratory depression, or in many cases, because the narcotic dose is so high, you get cardiac depression and death follows very quickly. So it's about 50 to 100 times more potent. My literature tells me it's 88 times more potent. I think you get the message here. But its action is shorter than every other narcotic that's out there. It only lasts about 15 minutes. Is that enough time to kill somebody? Absolutely. All you need is respiratory depression, then respiratory arrest for 4 to 6 minutes, and you got your brain dead. If they do one of the purified fentanyls, they can drop their blood pressure down to 0/0, and they're not going to be around much longer at all. So shorter duration means that we can assess people a whole lot better in the emergency department. Now, this is where it does become important, and it's not necessarily going to rely on the CT scan, but if I get a multiply injured patient from a car accident, and you give me a mechanism of injury that says that this was a really wicked accident, fine, loading up with fentanyl all day, I'm just going to spin them through the CT scanner. But for the patient who comes in with maybe just some injuries, but not total body injuries, the use of fentanyl is a big advantage here because 15 minutes after you give it, their pain's coming back, and I can do a more focused exam. And maybe I don't have to do a head, neck, chest, abdomen, pelvis CT scan. Maybe I only have to do a head, neck. So from that standpoint, we prefer it in traumas, not only because it doesn't drop the blood pressure, it gives great pain relief, but it's fast on, fast off. F, fentanyl, fast on, fast off. And for a lot of good reasons, it becomes desirable to use fentanyl. Now, analgesia and sedation. That's pretty much the hallmark of all the narcotics, Demerol, Dilaudid, morphine, and fentanyl. Alterations in the respiratory rate, the depression of the respiratory drive is influenced by the dose of the medication that you give. So I like to keep the fentanyl between 100 and 200 mics, 1 mic per kilo, if you will. Larger doses or that unusually purified fentanyl causes apnea. So it's a pharmacokinetics are that it's an immediate onset. Peaks in 3 to 5 minutes, and although its duration is 30 to 60 minutes, we dose it every 15 minutes because its desired effect, its best effect, its peak effect is between 3 and 5 minutes. Well, if you peak at 3 to 5, what happens after the peak? You're coming down. So after about 15 minutes, even though the duration on this slide says 30 to 60 minutes, I can assure you anybody who gets fentanyl is back on the nurse call button after 15 minutes because it pretty much goes away. And if you got the stressed out individual who's just been involved in a multiple trauma, they're pumping their blood around their body pretty quick. Fentanyl gets metabolized very quickly by the liver, gets broken down. Not enough in some cases to prevent deaths, but certainly when you give it therapeutic doses, I'm supposed to use this dose range, it can clear pretty quickly. We use it as an adjunct in RSI intubation and the first item there, maintenance and analgesia. If I've got a very painful condition and I have got the patient intubated, I'll give fentanyl, I'll give ketamine, and then I paralyze them with VAC. Okay, I got the pain under control, and I've got the hypnotic on board so that they're really, really sedate, and then I put the paralytics on them. Now, to maintain them in the intensive care unit, I'll put them on a Versed drip and a fentanyl drip. And if I keep the fentanyl at maybe 400 mics an hour, which is equivalent to 100 mics every 15 minutes, and I keep the Versed at 5 milligrams per hour on an intubated, mechanically ventilated patient, I should be in pretty good shape here. I sometimes have to get that Versed up because Versed is short acting as well. I may have to go 10 milligrams on that. The bottom line being is that it's great to maintain analgesia. You may have heard patient-controlled analgesia, where a patient is put on one of those pain pumps. Fentanyl can be one of the drugs. They push the button, they get 100 mics. They can push the button all day. It's not going to give them another dose for 10 to 15 minutes. And subsequently, when they press the next time, let's say it's 30 minutes later. Let's say they got good pain relief and 30 minutes later starting to come back. They press it, delivers 100 mics once again. And so that's patient-controlled analgesia. You get that in the hospitals when a patient's just been through some very wicked stuff that causes them to have an incredible amount of pain. Back pain, back surgeries is one of those examples. Contraindications, what's severe hemorrhage? Hypovolemia. You saw that on a previous slide with morphine. Hypovolemia. Shock, what's that? Hypovolemia. So we're back to that again, and of course, am I allergic to it? Never known anybody allergic to fentanyl. Seems like the stronger the narcotic, the less number of people are allergic to it. You got a boatload of people that say they're allergic to morphine and they can only take Dilaudid or hydrocodone. It defies explanation, and it's a medical miracle that they're like that, but they're like that. Okay, precautions. You give anybody a narc in the field, they're on at least a 4-lead. They're on a pulse oximetry. Preferably, they're on end-tidal CO2 because you want to see if the CO2 is building before the pulse oximetry crashes. And you will see the CO2 going up because of respiratory depression and decreased sensation of the brainstem receptors to higher CO2. And that's one of the problems of the mu receptors. When you block those, you get some spillover into the kappa, and respiratory depression can be masked with the narcotics. Okay, may produce bradycardia. I don't know what to do with that. Yeah, anything can happen. Patients with liver and kidney disease have a decreased ability to break down and excrete the medication. this isn't so much with kidney disease, but it's definitely true about liver disease. If you get on the scene, you got somebody who's got a beach ball underneath their shirt, and they've just got one big old round abdomens, but yet they got a skinny body with it, and they're turning, by the way, yellow. Their liver cirrhosis, the classic alcoholic is liver cirrhotic. They don't have much of the liver left. So if you give 100 mics of fentanyl, it could very well stick around for an hour because the liver has lost all its ability to clear and metabolize the narcotic, can't break it down, and here's the fentanyl going around and around and around the body, just having a great old time without it ever being broken down by the liver. Fentanyl in a normal patient with a normal liver, you give it in about 15 minutes, they're going to require more pain medicine because the liver is really good at metabolizing it into inert products. And then they go out the body. But liver disease, you're going to have to watch that with the narcotics. And here we go again. The fifth item is a big one. Less emesis with fentanyl than there is the others, because we feel that histamine is a big component of when a narcotic is given. Histamine may be released. Those patients can precipitate vomiting. It's one of the proposed theories, but we're not quite sure why narcotics cause vomiting in people. More times than not, in the emergency department, I anticipate that the patient may get nauseous, especially if they're hypovolemic. They've been thrown up for 3 days from their pancreatitis or from their gallbladder attacks, whatever. They finally come in the emergency room, tachycardic. I'll put a liter of fluids on them and get that running right away, and then give them the pain medications. Number one, it'll help maintain their blood pressure. Number two, it will blunt any vomiting that they may have. I may be able to get or prevent the nausea and vomiting to begin with. So in addition to when you're going to give your patient narcotics, IV, you're going to have your IV fluids running, you're going to have your cardiac monitor on, you're going to have your ETCO2 on, you're going to give your fentanyl or your morphine, and you're properly monitoring the patient. Now, one of these here, let me go back, muscle rigidity. Fentanyl has kind of a ketamine looking type, same side effect. If fentanyl is pushed slowly, you'll have no problems. If you push fentanyl like you're caulking a window, you're going to get some chest rigidity. Same thing with ketamine. You're going to get a rigid chest. You're not quite sure why that happens and why it's limited to fentanyl and not the morphine, Dilaudid, or Demerol. It's just a phenomenon that we see with fentanyl. I can't even explain it with histamine use. It's got to be something else that does this. But for the most part, you can see chest wall rigidity if you push fentanyl too quickly. So obviously we profess any dosage of fentanyl, 1 minute to 2 minutes on the push. And then the only thing that you have to know for the National Registry is that you don't want to give any narcotics when they're on MAO inhibitors, monoamine oxidase inhibitors. It's an older class of blood pressure medications. They've pretty much fallen by the wayside. But every once in a while you see one pop up like Nardil or doxycycline or one of those older medications. Everything's been replaced with the newer, brighter, shiny penny type blood pressure control medications like angiotensin renin blockades and the selective beta-1 beta blockers. And of course, the diuretics have been mainstay. The ACE inhibitors, the calcium channel blockers. All of these are very safe with narcotic use. But the old MAO inhibitors, there's still enough of them around, and we still teach it that you have to watch out for MAOs. So in your sample history, before you start giving anybody any medications, make sure you're covering what medications they're on so that you know if they're on an MAO. Everybody carries cell phones. If you see a medication that you don't recognize, pop it into the cell phone. Just make sure it's not an MAO before you start giving narcotics. What happens is that the patient precipitously drops their blood pressure and it crashes like nobody's business. Even fentanyl will cause a crash in blood pressure because when it combines with the MAO inhibitors, it's one of those rare 1 + 1 = 3 reactions. It is potentiated many fold by the MAOs. So just the only thing that you have to know for the National Registry, if it even shows up on one of your questions, it depends on what cycle you're in, but they may say, what are contraindications narcotics? Hypersensitivity, hypotension, hypovolemia, and MAO inhibitors. That's the way your question will look. All of the above, none of the above, some of the above, whatever. Okay, so the dose of fentanyl is going to be 25 to 100 mics over 1 minute, preferably over 2 minutes. We can also atomize this. So if you get the MAD device, you can squirt 1 ml on each side and you get 50 on one side, 50 on the other. That's 100 mics. You're good to go. And this is particularly advantageous for people that you can't get IVs on, or people that have a kind of a temporary pain issue going on right now and you don't want to get into IVs and such because you know the ER is going to get into all this, or maybe something more sophisticated. Or you need to get them to the hospital fairly quickly, but you got to get some sort of pain control. Whatever your reason is for using an atomizer is fine with me. Just know that fentanyl can be atomized, and it's a very effective way to deliver it. I may even give 25 mics intranasally to a kid that comes in the emergency department. It's good pain control. And what do we know about fentanyl? It starts with an F, and we know that stands for fast on, fast off. The kid is going to be nice and sedate for a bit. They're going to be pain-free. They're not going to be crying. And about 15 minutes later, 20 minutes later, they're going to be starting to cry again. But this time we got them in the ER. We can get the IV started and such. Anxiety level is down. Same thing with you in the field. If you got to squirt a child and then throw a splint on them to get their badly deformed wrist or forearm fixed, to get one of those air splints on, or one of those total body cat, whatever you're going to be using. Fentanyl is very effective intranasal. You don't have to give IM shots or nothing. Squirt in the nostril, 25 micrograms for most kids. Boom. Splint them and you're on your way to the hospital. Kid's happy, mom's happy. If mom's happy and the kid's happy, you're happy. Okay. Let's see, 1.7 to 3.3 micrograms per kilogram. You know what you may want to do? You may want to use a Brazlo tape here, because memorizing 1.7 to 3.3, it doesn't help anybody. Use your Brazlo. If you got a kid that's out there, Brazlo tape them and then look it up and go, oh, fentanyl dose. Okay, this is what I'm going to give them. 25 mics in this nasal passage, and if they're a bigger kid, 25 in the next one, you're good to go. Shouldn't go any more than 1 milliliter in each nary atomizing. Okay, that we kind of draw a line of 1 ml. Past that, the gagging, choking, or they just blow it right back out at you. Okay, I'm going to cut off here. We talked about morphine and fentanyl. We talked about their indications and contraindications. Next month, we're going to start on, not on nitrous, because nobody uses nitrous. Why? Because when they brought nitrous into the fire departments many years ago when I was on the fire department, they noticed that every shift check off, there was less and less nitrous in the bottles. And yet they hadn't used it on any any EMS runs. Why? Because a bunch of us got stupid and went in the back of the ambulance and we all passed around the mask and do the nitrous ourselves, got dumb stupid, and subsequently burned through several $1,000s worth of bottles. So they figured out that it was their own firemen that were sniffing this stuff during the day, during their shift. So quite frankly, they ditched it for reasons other than pain control that's out there. And that's just kind of a little aside, some fun fact for you to know. So let's see where we're going to pick up next time. Stadol and Nubane aren't really tested anymore. We will pick up with Toradol. We'll cover a little bit about that, and then we'll start getting into sedatives. So does anybody have any questions before we break for the night?
I've got a question on fentanyl.
Okay.
I know it's kind of the big opioid going around where overdose and everything. Is there a difference in a fentanyl overdose than regular narcotic overdoses that we can recognize in the field, or what?
No.
No.
All narcotic overdoses look the same. Pinpoint
that's what I thought.
pupils, decreased respirations, decreased cardiac output. You wouldn't be able to tell the difference between fentanyl and morphine overdose.
All right. Thank you.
No problem.
Does fentanyl in the MAD device, does it burn at all in the nostrils?
No. I mean, everybody's different, but for the most part, no. We haven't seen that kind of side effect with fentanyl with anybody, at least not that I know of. And it's not reported really as anything more than a side effect that we have to be worried about.
Okay.
Would you also up the dose of it if you're going to give it in a nasal, like you would an ET tube?
Yes, I would. We teach the regular doses at 25 mics, whether it's IV or atomized, but from a field paramedic standpoint, let's say we're all done with the National Registry. Now I'm teaching you how to really give good field medicine. The answer to that is yes, Marguerite. We would give a little bit more, maybe 50 or 75 mics to achieve the same effect.
So about double, at least about double of the
1.5
IV
to 2, yeah, I'll call it that. 1.5 to 2 times.
Okay, thank
No problem.
you.
Anybody else? All right.
Hey, I'm going to hit the list here to make sure they're still there. Keaton, did you have any questions?
No, ma'am, not yet.
All righty. How about Randy? I know you talked earlier, but you got any questions now?
No, ma'am, I don't have any more questions.
All right, Ryan Smith, how about you, my friend?
No, ma'am, I don't have any questions. I feel like it was pretty thorough.
All righty then. Well, we have another MD roundtable on the 14th